Inviting the next speaker, Dr. Gitansha Sachdev, to speak about planning surgical procedures and outcome evaluation using the Femto LDV Z8.
A very good afternoon. Today I'll be discussing the planning, the surgical procedure, and the clinical outcomes. I have no financial disclosure. Now, the CLEAR is the lenticule application by the Zymer Femto LDV. As Michael has alluded to beautifully, what we get here is a low energy per pulse and a very high repetition rate. So what that clinically translates into is a very accurate laser focus, which results in a very smooth resection. Just a brief on the machine. The patient interface here is a handheld system, and unlike a lot of the earlier platforms, this is a system to the patient dock, unlike a patient to the system dock. It can be done either in a single step or in a two-step, wherein first the patient interface is lowered onto the eye, and after the vacuum, the laser delivery handpiece is subsequently docked. It has a conjunctival suction with a higher vacuum, so the incidence of suction loss is exceedingly rare with the CLEAR. Now, when we discuss the centration options, one of the important things or advantage of this is that the centration can be manually altered even after the docking has been complete. It can be done either on the pupil manually or with a marker. A pupil centering might not be as effective because we're using an applanating interface and the vertex of the cornea vis-a-vis the pupil is slightly distorted. If we're doing the manual fixation wherein the patient is asked to look at the fixation light, it will be better to do the dock as a single dock, because if we do it as a two-step dock, once the patient interface vacuum has been initiated, the visibility of the patient is not there and he will not be able to look at the fixation light. Another method would be to just mark the Purkinje image on the cornea and center it on that. Cyclotorsion compensation has already been discussed. This platform additionally gives you corneal side cuts which lead either to the anterior plane or the posterior plane. In my personal experience, the posterior lenticule did not significantly help in getting the plane right vis-a-vis just a regular side cut, but this can be used as a rescue incision wherein if for the initial learning curve, the lenticule has been dissected posteriorly, the other incision can be used to get the plane right. The software allows for venting incisions. This is essentially because it is an applanating dock and we need venting incisions for the OBL to be released. In our experience, we have preferred a venting incision at both the posterior as well as the anterior plane, wherein the OBL was better and the visual recovery and dissection was faster. A word on the lenticule morphology. Now this, as against some of the other platforms, has a tapering edge of the posterior surface of the lenticule because there is no vertical lenticule cut. How this might help clinically is that it might give you a slightly larger optic zone as compared to one where the ending or the cut is more abrupt. However, there has been a study that has been conducted in 40 eyes, and it shows that the effective optic zone was around 13% lesser than what was programmed, which is similar to other platforms. So this is just a brief of the treatment parameters, which is very similar to the other available platforms. Now, one thing I would like to highlight is the mobility of the machine. This machine can truly be moved from center to center. So this is a van that we use in our hospitals. We have designed this with a hydraulic lift, which essentially moves along the X and the Y axis, which allows to transport this with relative ease. And it goes every week in 6 centers across 400 kilometers. And we've done over 1,000 eyes in last year and a half. So this is one advantage. This financial viability of the machine is a major advantage with the CLEAR software. So I'll just briefly discuss the surgical procedure. This is the marking. These marks on the horizontal and the vertical axis were for cyclotorsion. Additionally, the first Purkinje image is marked on the cornea for centration. This Q factor can This machine allows for the compensation of the Q factor, which helps to reduce the spherical aberrations which are induced because of the refractive procedure as such. Once the parameters have been fed in and the incisions have been planned, we go ahead with a docking. This is a single stage wherein the patient interface and the machine has been docked in the same sitting. So an advantage of this is that even after the dock has been achieved, one can manually center the treatment. You can see that it is now being manually centered on the Purkinje image, which was marked on the cornea. Next, we go ahead with the cyclotorsion compensation, which has been done. This is an ASOCT image, which is available intraoperatively and shows you the position of the lenticule. So this begins with a venting incision for the posterior surface, followed by a spiral in pattern for the posterior cut. It then goes ahead with a venting surface for the anterior lenticule and the anterior lenticule cut, followed by the corneal side cut. So the procedure is the same as is with all CLEX procedures. We go ahead by entering vertically and opening the corneal side cut, which is then followed by delineating both the anterior and the posterior planes. This is then followed by a complete dissection of the anterior plane of the lenticule from the overlying cap. One has to be a little bit cautious at this area where the venting incision meets the cuts, because there's slightly more resistance than is for the rest of it, but it's very easy to overcome. Once the anterior dissection is complete, we go ahead with the dissection of the posterior surface. I generally prefer to do half of the inferior half of the lenticule first on both the sides and leave behind a slight wedge, which essentially allows for a counter traction and prevents the lenticule from giving way or folding over when the rest of the dissection is being carried out. So once that is done, I just go ahead and dissect the remaining wedge, and the lenticule can be removed easily as a whole. The dissection here is very smooth because of the dense overlapping spots. So how are the outcomes with CLEAR thus far? This is a study of 53 eyes that was published, and it showed fairly good visual outcomes. 21% gained one or more line of CDVA. The postoperative UDVA was better than 20/20 in 51% of the eyes, but it is important to note that preoperatively the CDVA was only 20/20 or better in just 57% of the eyes. In terms of predictability, accuracy, and astigmatisms, the results were as good as the other platforms. No cases of suction loss or aborted treatment were noted. So these are our initial results of around 390 eyes with the platform. This is a fairly busy slide, but you can see that the sphere, the cylinder, the MRIC have significantly improved, and so has the corrected distance visual acuity. So in terms of efficacy, a postoperative UDVA of 20/20 or better was achieved in 88% of the eyes, and 8% of our eyes gained a line or more of CDVA. Again, in terms of predictability, astigmatism, and any postoperative complications, the results were very good. This is just a quick analysis I did of the eyes, just to compare two platforms, a curved versus an applanating. We did this for about 150 eyes each, and we had used matched cohorts for both the sphere, cylinder, the MRIC we were treating, and the postoperative results in 6 months were not significantly different. We also used the Circle software, which is provided by the Visumax, for an off-label retreatment in eyes that had undergone CLEAR. These are just the data. We had done this in 9 eyes, and we were able to successfully treat all 9 eyes that had undergone CLEAR without any cases of buttonhole or any issues with the flap. So I'd just like to conclude that the outcomes thus far are exceedingly promising. Lower complication rates of suction loss is definitely one of the advantages that this platform has to offer, and it does give you a true mobility which allows this technology to be delivered at multiple centers. Thank you.
Thank you, ma'am.
Regarding the mobility, I have a question. When you move the machine from one place to another, do you recalibrate or do something? Is like do you have a protocol set in at every place to like reset the machine or set up again? What do you do?
So, am I audible? So we have an in-house technician who goes with the machine. So we cover 6 centers in 6 days. It requires a warm-up every time, so it takes about 2 hours for the machine to warm up, and it's recalibrated before every use.
Great.